Bob Hopkin. I am a pediatrician and a geneticist, and I'm going to be talking about Fabry disease. The focus of this talk is Fabry disease for pediatricians, emphasizing the role that pediatricians will play in the care and management of children with Fabry disease. So the roles of a pediatrician in general are to first recognize that there's a problem, second, ensure that the evaluation is done and that it is appropriately instituted, then follow up on the results of whatever the initial evaluation is, see to it that appropriate interventions are implemented, and monitor the response to those implementations. So with that in mind, we're going to talk about Fabry disease, which is a somewhat rare disorder, but that has important implications for children. All right, so Fabry disease is a lysosomal storage disease due to deficiency in alpha-galactosidase A. And that results, so the role of that enzyme is to break down a complex, almost unpronounceable molecule called globotriacylceramide into galactose and a smaller molecule. And if that doesn't happen, you get buildup of that molecule in the cells, and that buildup over years eventually results in cell dysfunction, cell death, and damage to the organs that are involved. And we'll talk more about what those organs are in a moment. So in the case of Fabry disease, there are multiple organs that need to be involved. So the storage, you can see in the center of this slide, builds up, and that leads to problems in blood vessels, which results in damage to kidneys, heart, brain, intestines, eyes, peripheral nerves, and other organs. So this is truly a multi-systemic disorder. Some of the features of Fabry disease that we look for on physical exam, you can see on this slide. So the purple spots on the lips, hands, and belly button of these patients are called angiokeratomas. They are vascular abnormalities. They don't blanch with pressure, and they do stick up a little bit on physical exam. Now, the challenge with this is in a pediatric population, you may not see these. These typically aren't present until adolescence, and they're not very commonly seen in female patients. This is another finding. So the top picture here shows, you can see some spoke-like abnormalities in the cornea of the eye. Those are referred to as corneal whorls. The challenge here is that you can't see them using routine physical examination. You need a slit lamp to do that, so pediatric ophthalmologists or adult ophthalmologists will see those. They are a valuable diagnostic tool, but they don't actually interfere with vision very much. The bottom picture shows some abnormal blood vessels on the sclera of an eye, but you can also get that in the retina. Those abnormal blood vessels, again, don't directly interfere with vision, but they are an important finding. However, if the storage in the blood vessels results in occlusion of the blood vessel, you see death of the surrounding tissues. In your retina, which is the part of your eye that gathers light and interprets vision, that can be a huge problem because you'll get partial blindness. So clinical presentation of Fabry disease is complicated. One of the key organs involved is the kidney. In this case, what we're seeing is storage in the kidneys. These are podocytes. This is a blood vessel that's got thickening of the blood vessel wall, and this storage in the kidney is actually visible even prenatally, and it continues to increase throughout the life of the patient. Now you have a list of problems here that can happen in the kidney. The damage to the kidneys is not detectable in early childhood. And in fact, patients will become symptomatic from other problems prior to developing active renal disease. So this is a big challenge. However, the reason I started with kidney disease for clinical presentation is that renal disease has been the leading cause of death in males with Fabry disease. If the treatment is if there's not treatment available, the kidney failure typically, however, does not occur until they're in their 30s to 50s. But you will see albuminuria and proteinuria starting in adolescence. Heart disease is another major issue with Fabry disease. Again, this is primarily an adult problem. The thickening that you see here on the heart disease is very advanced, but you see thickening of the heart, you see abnormal heart valves and disturbances in the rhythm of the heart, generally starting in adulthood, but you can see those problems starting again in adolescence. Heart disease is currently the leading cause of death for individuals with Fabry disease. Okay. Brain abnormalities. So what you see on these images in older patients is white spots here, and then this is a different patient over here and over here. This is a normal brain at the top. What you see in people with Fabry disease is these white spots show up. Those are signs of vascular insufficiency and damage to the brain. You can also see strokes in individuals with Fabry disease. The strokes are referred to as early, although most of the strokes occur in adulthood, but at a younger age than is typical for adults. There are some cases of pediatric strokes reported, but this is seen in less than 1% of children with Fabry disease. Now, those are sort of the major life-threatening organs that we look at for Fabry disease. And so far, you will note that for the kidney disease, the heart disease, and the brain disease, that the major problems occur primarily in adulthood. Now, this is an image of results for quality of life this is adults with Fabry disease. And what we're looking at here, you will note that so the patients in these cases, in these studies, were age 14 to 40. And what you will note is that even at age 14, in the males, you already have relatively low scores. Normal scores would be up in this range, around 90 to 100. And lower scores are seen in all of the categories in males. And then in the females, you have the typical scores again around 90, and most of the areas in females at age 14 to 20 are in the normal range. However, what you see with females is a decrease over time, such that the scores are normal in the 14 to 20-year-olds and nearly the same as the men in the later adulthood. Survival in patients with Fabry disease is also impacted. If you look here at the males and you come down to the 50% survival range, that is happening right around age 50. This is untreated Fabry disease. And in females, it's a little bit later, but you still lose a significant amount of life and of quality of life. So now that, again, adult manifestations, what we're reviewing right now is just overall. This is starting to get into implications for children. So the onset for symptoms in this slide is about 10 years of age on average, and that is a retrospect. We'll talk a little bit more about age of onset later on. And then if you look over here at the start of treatment, and this slide was data from 2006, but we just re-looked at this, and it hasn't changed, at least not appreciably. And the average age for starting treatment for Fabry disease is right around 38 to 40 years old. That is potentially a problem for a disease that's continuously adding to the damage of your body, to your body. So one of the roles of the pediatrician is to make sure that we recognize Fabry disease at this point, where the symptoms are having their first onset, and that allows us then to do something about this disease and hopefully prevent the more serious complications that are happening out here. You will note that the age for renal problems, heart problems, and strokes comes right about the same age as the initiation of therapy. Again, that is not ideal. So far we've talked about some of the physical features that we can see, but those may not be visible in childhood. We've talked about the major life-threatening problems associated with Fabry disease, and those happen in adulthood. Now we're talking about, well, when should I think about Fabry disease? And this is going to be things that will happen more in pediatric age range. So right now, the most common reason that somebody is evaluated for Fabry disease is because they have a family history. So when to look for Fabry disease, this slide is the easy things. You don't have to think about it. If you see these problems, you need to think of Fabry disease. If somebody comes in and tells you that they have a family history of Fabry disease, that's kind of a simple one. Typically, if a new patient is diagnosed with Fabry disease, there are about 5 affected relatives at risk that can be identified. So we want to identify all of those people, and we want to make sure that they get tested. Second thing, angiokeratomas that I showed you pictures of before. They're purple spots. They're easily overlooked. The key place to look for people with Fabry disease is in the belly button and the groin. But they also can show up on the palms of the hands, on the lips, and in other areas. So if you see those, evaluating for Fabry disease, there are potentially other causes, but angiokeratomas are most commonly associated with Fabry disease. The corneal lesions, I wouldn't expect most pediatricians to identify, because I know when I was doing general pediatrics, we never had a slit lamp in clinic. But if the ophthalmologist reports to you that there are corneal lesions, corneal whorls or spoke-like lesions, and especially if they say typical of Fabry disease, that needs to be tested. The other causes for that there are a few other causes. They include anti-malarial therapies and some anti-arrhythmic therapies. Abnormal tissue biopsy. So if a child has a kidney biopsy or a skin biopsy, and inclusions are noted suggestive of a storage disease, that would be another reason to test for Fabry disease. Those are easy, straightforward. You should never miss those. Okay, when to think of Fabry disease? A little bit harder, but times when it should cross your mind. So if a child has proteinuria and you have no cause, Fabry disease is not at the top of the list, but it's one of the things that might be involved, and it's an important one because there's a specific treatment for it. Hypertrophic cardiomyopathy, again, Fabry disease isn't the most common cause of that, but Fabry disease is one of the things on the list, and the treatment for Fabry disease is different than the other common causes. Early onset stroke, only 3 or 4% of early stroke will be related to Fabry disease, but it is an important cause. That will generally, the strokes will generally be in adults, but at a relatively young age. You can start to see proteinuria and hypertrophic cardiomyopathy in adolescents. These findings are much more compelling if you have more than one of them, or if you do if you see one of these and then you do a family history and find other problems in the family history. That would be, again, strong evidence that you should think about Fabry disease and initiate further workup. Okay, when to think of Fabry disease? This is for the people who want to be master clinicians. If you want to be the guy who makes the difficult call and is the hero for the family, these are the times when you'll think of it. So in pediatric patients particularly, chronic or recurrent diarrhea without evidence of an acute illness. No fever, no nausea, just diarrhea, and especially if it's post-meals. So the child eats and then they gotta go right now and they're having diarrhea, that's a time to consider Fabry disease. If you have a child who can't tolerate exercise or hot weather due to decreased sweating, think of Fabry disease in addition to things like ectodermal dysplasia. Chronic fatigue is very non-specific, so that by itself probably doesn't warrant testing. But if you have chronic fatigue and you ask about recurrent abdominal distress or decreased sweating and you get positive history of those, think of Fabry disease. Family history, but not specifically dating that family history of Fabry disease, but if you get a family history in a child of early strokes, renal disease in multiple individuals, or of heart disease, and especially if that's accompanied by pain in the hands and feet, either in the child that you're evaluating or in the affected family members, you're going to look very good if you think, oh, this could be Fabry disease. Now, Fabry disease is a fairly rare disorder. The classical form of Fabry disease, which is what you're worried about in children, is only about 1 in 40,000. But it does tend to cluster, so if you have one family, you're likely to have more than one patient. Now, if you think of Fabry disease, how do you confirm your diagnosis? So there's a little bit of a difference between boys and girls because this is an X-linked disorder. However, it's an X-linked disorder that affects both males and females. So you want to pay attention to the girls, but the way that you confirm the diagnosis is not the same. So in a boy where you need to know, is there Fabry disease, the standard test has typically been to measure the enzyme activity. And that can be done through a number of labs. So if you find a lab that does biochemical genetic testing, you can ask them, ask for that testing to be done. You can also test boys by sequencing the gene, the AGAL gene, and doing molecular studies for Fabry disease. If they find a mutation that has been associated with disease or that would lead to incomplete protein, and you have a diagnosis. If you do not find a mutation and there's a family history of Fabry disease, then you can ask if anybody in the family has had testing. If they have and it was identifiable with standard molecular testing, then that child probably doesn't have Fabry disease. If the family mutation isn't known, or if the child is being evaluated based on symptoms, in a male child you would then need to do enzyme activity to be sure that the child didn't have Fabry disease. Occasionally we will have boys with Fabry disease identified because they required a kidney biopsy, a heart biopsy, or a skin biopsy and found the typical inclusions. We confirm the diagnosis at that point with either the molecular study or the enzyme assay. For girls, because it's an X-linked disorder, they have 2 copies of the gene, and with random X-inactivation, they will have some cells that produce the enzyme and some that do not. That does not keep the females from having disease, but it does make it so the enzyme test as a blood test is not reliable. So, generally speaking, if you want to rule out Fabry disease in a girl, you want to do a molecular test. If you, for some reason, cannot do a molecular test, although that would be a really exceptional circumstance, a kidney biopsy or a heart biopsy could be substituted. All of my patients prefer the molecular testing, which is a simple blood test. Okay, the genetics, as I mentioned, this is an X-linked disease. It affects males and females, but males are symptomatic earlier and are typically more severely affected. That is in part due to X-inactivation. So this diagram shows the light-colored image are the people with Fabry disease. The blue ones are the people without Fabry disease. So in this case, if you have a male with Fabry disease and he fathers children, all of his daughters will inherit the mutation. He only has 1 copy of the X chromosome. It has a mutation that causes Fabry disease. All of the daughters will get that X chromosome. All of the daughters will have Fabry disease, with some very unusual exceptions. And none of that man's sons will have Fabry disease. So who's at risk when the father has Fabry disease is pretty straightforward. The daughters are obligate to inherit the disease causing mutation, and the sons will not have that. It's a little bit more complicated when the mother has a mutation in the gene because she has 2 copies of the X chromosome and can pass either of those copies on to sons and daughters. So half of her sons and half of her daughters will inherit that, which means the offspring of a woman with Fabry disease are at 50% risk, regardless of whether they are male or female, and you have to do testing to find out if they have Fabry disease. For the boys, you can test either enzyme activity or the molecular test. For the girls, you would have to do gene testing or molecular testing. So, do you need to know what the mutation is? So until recently, I would have said all you need to know is that there's a mutation, and knowing what the mutation is doesn't make any difference. Fabry disease occurs in 1 in 40,000 individuals for the classical form, but More recently, people have started doing newborn screening for Fabry disease in some places. And they found something that's a little bit troubling. And that is that about 1 in 3,000 people will have a low enzyme activity level on the newborn screen. Some of those people will have non-classical Fabry disease that tends to present later in life, but will eventually result in either heart disease, kidney disease, or stroke, but usually does not have the pediatric problems of pain and GI symptoms. Some of the patients, however, will have a low enzyme value but will not develop disease. So in order to distinguish those two currently, it's very helpful to know what the mutation is. The other thing is that since we have now classical Fabry disease and non-classical Fabry disease, differentiating between those, it's very helpful to know what the disease is. Finally, there are studies being done to develop newer therapies for Fabry disease, including something called chaperone therapy. A chaperone is a small molecule that attaches to a protein and can stabilize it in the body. So if the chaperone therapy becomes an available treatment, only some mutations will respond to the chaperone therapy, and then it will be critical to know the mutation that your patient has. So what types of mutations are there? You can have a deletion of the gene, so the whole gene that causes, the AGAL gene is missing. You can have a frame shift mutation in which part of the gene is missing and the disruption to the DNA changes the clustering of the letters so that it is out of reading frame, and I'll give you some examples of this in a minute. And nonsense mutations, which are just a stop sign in the gene, splice site mutations, and missense mutations. Okay, so now let's go, what are those? Frame shift mutations. So if we start with the phrase, the old man and the sea, and I chose that one because it's in 3-letter groupings, DNA coding for proteins. For amino acids, if you will remember, is in triplets. So if you shift the frame, either by inserting a letter or by deleting a letter, you get incomprehensible after the change. So in the second example here, there's an inserted A, and you go from the old man and the sea to the, I don't know what those things mean. And if you delete a letter, you get the same thing, and you can do that. So in the first 2 examples, it's right after the first triplet, but you can get that at any point in the gene. So the last example is one where you have a frame shift later in the gene. Frame shift mutations result in the vast majority of cases in no enzyme activity at all. Okay. Nonsense mutations are a little bit different because there's not a frame shift. Basically, with a nonsense mutation, you have a point mutation that is the equivalent of putting up a stop sign in the gene, so that transcription stops, no protein is made. That is important because it may be possible in some cases to restart the gene or to blow through the stop sign. That is not currently available, but is being looked at. Okay. Splice sites. So our genes do not just read through in a protein as a single continuous thing, but there are punctuation points in it. And at those points, the RNA has to be spliced. So if you get a splice site mutation, instead of saying the old man in the sea, you get some of the stuff that would be involved in the instructions for that might be inserted, the insert space here, old man and the sea, which changes the meaning of the term, or you could be missing things. The old man, the sea, or the old, the sea, and that again changes the meaning of the terms. Missense mutations are changes of only a single point. So if you read the phrases on here, you will see that it's in frame, the right number of letters are there in most of these, and the phrase still is saying something, but it's not saying the same thing. You go, the old man and the sea, the odd man and the sea, the old man, damn the sea, etc. And that changes the meaning of the phrase. You can also get in-frame deletions. If a deletion is in frame, you can have some residual activity. Okay. So what difference do these make? So currently, the use of knowing your mutation is that it helps in testing other people. If you know the mutation in a family, you can order a test for that specific mutation, and that saves about $1,000 and makes the test much easier to interpret. So it's cheaper and better if you know what you're looking for. It also helps to predict the severity of the disease. If you have a mutation that predicts no enzyme activity, you're likely to have pediatric onset symptoms and more rapid progression of the disease. If you have a missense mutation that allows for some residual enzyme activity, you may have variant forms with later onset or with milder symptoms. So in short, it may be beneficial to know your mutation. So the X-inactivation that we've mentioned a couple of times, if the X-inactivation is skewed, meaning that you, instead of having a random selection of X's that are a mix of the one with the mutation and the one without a mutation, you have only one copy active. If the mutated copy is turned off, so that the active copy of the X chromosome has only the normal copy of the thing, those women are very fortunate, and they will usually have no problems at all related to Fabry disease. If you have skewed X inactivation such that the mutated copy of the gene is the one that's turned on, the women with that will have very severe disease, essentially indistinguishable from the disease that we see in the men. Most women will have in between those two. About 70% of women will have random X inactivation, and they will have a risk to develop symptoms, but the symptoms typically are milder and a little bit later onset than in males. So first symptoms. Now we're talking about children for the most part. So first symptom in most children is pain. The pain typically presents as burning pain in the hands and feet, although you can also get abdominal pain. The second most common symptom in children is gastrointestinal, and that can be abdominal pain, which is a very nonspecific feature, but it can also be a recurrent diarrhea, or in some cases gastroparesis with nausea. The nausea typically most severe in the morning. Occasionally you'll have children who will present with either angiokeratomas or the purple spots that we've shown previously, or with decreased sweating as their first presenting concern. Now, look at these first symptoms and notice the numbers on the cardiac, renal, and cerebrovascular. So this data is taken from the Fabry registry, and this particular run included several hundred pediatric age patients, and you're looking at very small numbers for the major potentially life-threatening organ involvement, which means those are not going to be your tip-offs in most cases for a pediatric disease. So the pediatric presenting symptoms, half of the kids with Fabry disease will have pain. So in the boys it was close to 60%, burning pain in the hands and feet, often quite severe. The females, it's a little bit less. They had about 40% reported pain, and the nature of the pain was also different, with approximately, with most of them not having the severe crisis level pain, which would be 8 to 10 out of 10 in severity. The girls typically report pain severity between 4 and 7, although some of them will have more severe pain. The age of onset reported by the pediatric patients for boys was about 7 years of age, and the girls was about 9 years of age. Now, the GI symptoms, boys and girls had an equal risk for reporting that symptom, with 27% having some GI symptoms, 19% having diarrhea as a major presenting symptom. Recurrent diarrhea is a significant issue as it results in missed school or in accidents at school, both of which are quite traumatizing to young children. Also of note, the age of onset for the boys with GI symptoms was a little bit younger than the age of onset for pain, so this is something to definitely pay attention to. Okay, we talked about this. Now, how big of an issue is Fabry disease for children? I've mentioned that the life-threatening complications do not occur very often in kids. So is this something that we need to look for in kids? We've mentioned that pain and GI symptoms are a problem. We also mentioned that fatigue can be a problem in pediatric patients. So a few years ago, we got curious, well, how big of a deal is this for children? So a graduate student was recruited, and we had her interview children and their families, and used the PEDS QL, which is a quality of life, health-related quality of life scale. And that, we interviewed 49 patients, and the results were pretty striking. If you will look down here on the p-value column, a p-value of 0.05 or less is significant. And what you will notice if you look down there is that in all of the categories, there was a significant impact. And in fact, this is clearly not only statistically significant, it's clinically significant in affecting the quality of life of the children. And this is combined male and female, but the statistics were significant when we broke it out and looked at boys and girls separately as well. So the brain findings in pediatric patients, so I showed you pictures of the findings in some older adults with Fabry disease, and we had those white spots. Those white spots can show up as early as age 7. They are, however, not typically present at that age. They are quite common going into early adulthood, and there aren't good studies showing how early those show up. Pediatric strokes can occur, but they are quite rare. In the most recent study of pediatric Fabry disease that is available with a large population, there were 352 patients. None of the pediatric patients had had strokes. However, in the population that I care for in Cincinnati, we have 3 patients who are currently adults who had well-documented strokes at between ages 9 and 18. I am aware of at least a dozen additional pediatric strokes. So they can occur, but they are probably less than 1% of the pediatric population. Okay. Treatment. So in the United States, there is only one treatment currently approved for Fabry disease. It is enzyme replacement therapy. The recommended dose in the US is 1 milligram per kilogram every 2 weeks. And enzyme replacement therapy is helpful, but it is not a cure. It is also a lifelong treatment. It requires an IV infusion, and the time for the infusions is typically between an hour and a half and 4 hours, depending on the patient and how well they tolerate that. Now, one of the things that has been noted is that if you start treatment early, you get better impact of the therapy. You get more complete clearance of the blood vessels, you get better impact on slowing the progression of damage to the kidneys, of damage to the heart, and better opportunity to either prevent or decrease the pain and gastrointestinal symptoms as well. The therapy does still have benefit even when started late, even when started with advanced kidney disease. So don't tell adults that it's just too late for them, but we do want to identify this disease in children because we think that that's the best time to start therapy. And there's a lot of debate about what is the best age to start that, and we won't go into that with this talk. Other therapies that are being developed, chaperone therapy I mentioned before. This could be given either with the enzyme infusions as a co-administration or in selected patients with mutations that respond to the chaperone therapy. It could be potentially used as a standalone therapy. Another category of therapy that is being developed but that is not currently available is substrate inhibition therapy. So if you think of the storage in the blood vessels as being a plumbing problem, and you have a bathtub, the enzyme therapy, so say you have a bathtub and the clog, the storage in this case, would clog up the drain of the bathtub. The enzyme therapy goes in and tries to unplug the clog. It's like Drano or Roto-Rooter or something like that. It's going to open up the pipes and allow the stored material to drain out. What the substrate inhibition therapy does is turn off the faucet, so that if you don't have any more water coming into the tub can't overflow, you don't get the mess. This approach is being used, is currently in clinical trials. If it works, it would be not mutation specific, and may be used either as a standalone therapy or in addition to the enzyme therapy, again, depending on the specific needs of the patient involved. Now, these treatments, as I said, are not a cure for Fabry disease, and they do not completely eliminate all of the findings or symptoms of Fabry disease. So we need to treat the specific problems in addition to treating the global disease. So the enzyme infusion therapy that we currently have treats the underlying cause of Fabry disease by minimizing the amount of storage and thereby minimizing the damage to the cells and to the organs in the body. But the patients who have symptoms may still require treatment of their symptoms. So pain being the key symptom in children with Fabry disease is an important one to pay attention to. So what do we do for it? One is, a lot of times there are specific triggers for pain. A lot of patients with Fabry disease will be very sensitive to either cold weather or hot weather. They will often get pain if they push their bodies. So if we make a patient with Fabry disease go out and run the mile, it is very likely that they will experience pain from that. We need to avoid those triggers and allow the patients to opt out of the things that we know are going to trigger pain. It is important to recognize that the pain in Fabry disease responds poorly to conventional analgesics. So using, and the most common ones, ibuprofen, being one of the most common, is a bad choice for Fabry disease because it damages the kidneys, and this is a kidney disease. So those are not the ideal choices. Narcotic pain medications will help with pain management in a severe crisis situation, but they are not good for long-term maintenance of pain control. So the mainstays of pain management are neuroleptic medications, and there are two categories of those. The anti-seizure medications, Neurontin, Lyrica, and Tegretol are the ones that are most frequently used. And antidepressant medications is the other category. And there are several of those that have been used successfully to treat. And it's not because the patients are depressed. It's because it stabilizes the nerves and helps to decrease the pain events that the patients experience. The drawback of the treatment of the pain with medications is that the medications have potential side effects, including fatigue and difficulty with focusing. So we don't want to over-treat, but we also don't want to ignore pain. Gastrointestinal symptoms, it is not clear if enzyme therapy will adequately control the gastrointestinal symptoms. There is some preliminary evidence that it decreases the symptoms, particularly the diarrhea, but other therapies may also be needed. For diarrhea, one of the useful things is just a stool thickener. So Questran, which was not developed for this purpose, but it binds water, and if you take Questran and it binds up the loose water in the stool, it doesn't completely eliminate the stool urgency, but it does allow enough time to get to the bathroom and not have an accident, which is important to the patients. For the patients with gastroparesis, which would manifest primarily as nausea, promotility agents such as metoclopramide can be useful. For the severe nausea, peppermint oil can also be an effective therapy in some cases. I've also had a number of patients report that eating a healthy diet that's high in vegetables, low in fats, helps them. And it is important, because gastrointestinal complaints are very common in children, to look for other causes of the gastrointestinal symptoms, and if identified, treat those causes. Okay. If you have a pediatric patient with proteinuria, The protein in the kidney, going through the kidneys and being lost through the kidneys, damages the kidneys and accelerates the damage to the kidneys. So that can be treated with ACE and ARB inhibitors. You would probably want to talk to your local nephrologist about that. Low blood pressure is a challenge because unlike other forms of kidney disease, Fabry disease is often not associated with high blood pressure. Renal insufficiency and high-grade proteinuria are rare in children, but if they occur, you will want to treat them. Renal failure has been reported in some pediatric patients, and patients with Fabry disease are candidates for dialysis and renal transplantation, although the goal, quite frankly, is to prevent that need. If you get high-grade proteinuria in a patient, in a pediatric patient with Fabry disease, you need to evaluate for other causes, and it is likely that a renal biopsy would be a part of that evaluation. So other symptom management, symptoms of cardiac disease are quite rare in pediatric patients, but there are some who have heart valve insufficiency and will require medications. It is possible that a pediatric patient would have symptomatic bradycardia or tachycardia, although that again would be quite unusual. Hypertrophic cardiomyopathy happens in about 1% of pediatric adolescents, usually looking at late adolescence. Symptom management for cerebrovascular disease, very rare in pediatric patients, but in adults, we would treat this with anticoagulant therapies, which would include potentially aspirin, but other anticoagulants may also be used. And acute management for stroke is the same as for other causes of stroke. If you have a patient with Fabry disease, you need to make sure that the patient and family know when to call, and that immediate institution of therapy is essential. So symptom management, quality of life. So the key thing for this aspect of Fabry disease is to have the patients, one, report what problems they are having so that they can be addressed. Two, lead a healthy, active lifestyle. Have realistic goals. So I have had some patients who had, for example, pain associated with Fabry disease. If they refuse to be active unless they are completely pain-free, that is going to be very difficult to achieve. And the side effects of the medications to achieve 100% freedom from any awareness of pain will probably not be a good idea. So you want to have a degree of control that allows for an active lifestyle, but that doesn't make the treatment more of a problem than the disease. Maintaining activities, maintaining social interaction is important, and patients in a pediatric age range do struggle with these issues. One of the key things that you can do as a pediatrician is to make sure that the school and families are aware of some of these needs. Patients with Fabry disease should have immediate access to get up and go to the restroom when they need to. They should be allowed to drink water and maintain hydration even in class. And they should be allowed to opt out of participation in sports or gym class when they are having pain. Now, I get asked all the time, how do you know? Because there aren't physical signs of the pain. And the answer is, I just have to trust the patients. Are some of the kids going to take advantage of that? Probably. But the pain is severe, the pain is real, and we can allow them to take advantage of it once in a while. If it gets to the point that they're really overstepping the bounds, then you may need to talk to them. Okay. Treatment for females is a little bit different than treatment for males. So in my male patients, I typically, if the mutation that they have predicts classic Fabry disease, I typically recommend that they consider starting therapy even without any symptoms at about age 10. If they have any symptoms, even if they're mild, I start at the time, before age 10, I start therapy at that point. And if the family of a male patient requests treatment prior to symptoms, even in very young children, I am open to that. And the reason for that is essentially 100% of the boys will develop progressive disease, and if we don't treat it, they will eventually go into renal failure, heart failure, or have a stroke. And early, especially if you've had relatives die from that disease and you want to prevent that from happening to your child, that's a reasonable goal. Earlier institution of therapy has been shown to be safe. It makes sense to at least open up for that discussion. Females are a little bit different because we expect about 15% will have no disease, and then a significant percentage of women will have later onset disease with problems only starting in their 40s or 50s, and some of them will not have any serious, some of those will still not have any life-threatening complications. So I do not have an automatic, you should start therapy here for asymptomatic females. Now, females who have symptoms should have the same policy as the boys. If a girl develops pain and she's only 6 years old, she should be put on therapy. If she develops recurrent diarrhea and she's only 5 years old, she should be put on therapy. Same as the boys. Anybody with symptoms should be put on therapy. On the other hand, if a female patient has no symptoms, typically what I do is recommend monitoring, and you have to monitor in the most sensitive ways that are available. This is a little bit problematic right now, but looking for any signs of kidney disease, any signs of heart disease, in addition to the pain, the fatigue, the gastrointestinal symptoms. Now, if a female with a strong family history of Fabry disease comes to me and wants therapy and is asymptomatic, what do I recommend? My recommendation is not going to be universal. This is Dr. Hopkin's opinion, but I would want, if I can, to get either a kidney biopsy or some detailed but not readily available assessments for biomarkers before initiating therapy in an asymptomatic female. That's not because I don't believe in treating the females, but it's because I don't want to treat people who aren't going to develop disease. Right now, the mutation status for females is not adequate to predict who will develop symptoms and who will not. Whereas the mutation status for the males is generally adequate for predicting who will develop disease and who will not. So, recommendations. Boys with classical Fabry disease beyond age 10, consider starting treatment. Girls, it is not clear unless they have symptoms. Symptomatic boys and girls should be on treatment. Monitoring is also essential. So if you put somebody on therapy for any disease, you should ask them how they're doing and see if your therapy is hitting the mark. So if you treat otitis media, you go back and you look in the ear. For Fabry disease, you have to monitor and make sure that you're hitting the target. How do we do that? So the needs change with time. Follow-up evaluations for people on or off treatment should include renal assessments. Current standards for that include calculated GFR, which is the filtration rate of the kidneys, a measurement of creatinine, quantitative measurement of urine protein and urine albumin, and that should be accompanied with a urine creatinine measurement so that you can calculate a albumin creatinine ratio, which is the most sensitive way of assessing kidney health that we have at the moment. Heart evaluations should be done in the pediatric age range because of the low frequency of significant heart disease. We don't do every year assessments of the heart. We do every 3 to 5 year assessments of the heart. And assessments of brain function or of doing MRIs to look for the white spots on the brain are controversial. There are people who recommend that, but there are also no clear decisions that will be based on that information. Pain, I recommend using a validated pain scale if you can. So the BPI, or there are a number of other pain scales. Always ask your patients about GI symptoms, and if they say yes, they have them, get the details so that you can tell if the symptoms are stable, getting worse, or getting better. Again, use of a validated scale is preferred, and I also like to use quality of life scales to monitor my patients. And with this approach, you can generally improve the outcomes for the patients, although, again, we do not have a cure for Fabry disease at this time. The long-term prognosis, I wish I could tell you if we started all of the boys on therapy at age 10, how would they do? But since the therapy was approved in 2003, we don't have data on what happens to pediatric patients who have been on therapy when they're in their 30s, 40s, and 50s. So we'll have to keep our eye on this for a while to get that information. Thank you.